Hello, everyone. Good morning, lunchtime, or evening, wherever you are dialing in today. I'm very happy to welcome you here on this breakout session on focusing on data and computer science, health technology, and engineering. I'm Timo Uustal, the founder CEO of NurseBeam, and for this summit, I was sponsored by EIT Health. We have, I think, I see 13 amazing Catalyst Awardees attending this session. I actually ask every one of you to turn on the webcam so we can get the cozy feeling as we are sitting in a nice round table. So don't be shy. Wherever you might be today in the Zoom, you can also use virtual background. So even maybe you're dialing in from the bathroom or the clinic or wherever that is, feel free to dial in. And so before we get started with Hidenori and Claude to introduce the Catalyst projects, maybe we can do also a quick around the table. You can just say what's your name and where you're dialing in today, and then we can get to the topic. So we can go maybe by the round. I see Catherine, you're the brave one.
Hi, everyone. My name is Catherine. I'm based in DC. I'll be the National Academy of Medicine staff for today's session. So if you need any help with anything, feel free to give me a direct message. Thanks.
Awesome, Catherine. Alex.
Hi, I'm Alex Wessner. I'm from the Boston area today. I'm one of the upcoming ventures in the program.
Awesome. Welcome, Alex, to the group. Marcos.
Hello, nice to meet you. I'm Marcos Zúñiga from Universidad Técnica Federico Santa María in Chile. It's a pleasure to be here.
Awesome. Also from South Hemisphere. So, Camille, hello to you, and where are you dialing in today?
Hey, hello guys. My name is Kamil and I'm from Medical Simulation Technologies and I'm from Krakow, Poland.
Awesome.
Thank you.
Hello, Camille. Li Peng.
Hello. Can you hear me?
Yes, we do.
Oh, sorry. Yeah, I'm actually isolating at home. I got COVID. So today is the last day. I'm going to be self-isolating myself. So pardon me if I off my video and I'm muting myself.
Well,
I'm from Singapore.
Awesome. And welcome to the group, Li Peng. And well, discussing wellness topics, that's the right place to be.
Yeah.
Then we also have Iliana.
Well, I'm a little bit in the dark. I'm talking from Israel. Can you hear me?
Yes, we do.
Okay, so I'm actually part of Catalyst Award with a group from Hong Kong, and they are the AI, the artificial intelligence experts, and I'm an expert on Alzheimer's disease. And we are trying to solve the disease, combining the expertise of biochemistry and biology and neuroscience and computer sciences.
Awesome. Well, welcome to the group, Ileana. I see that there is somebody called Zoom 3 and Zoom 3 PC. I think these are you artificial intelligence or a human? If you are human, let us know. If you are just okay. But now we can get started with two speakers for the session. First of all, we have Dr. Hidenori Arai from Japan, who will share his experience on the project of randomized controlled trial for dementia prevention by multimodal interventions. And if you have any questions, feel free to kind of note them down because later we have also space to ask questions from Hidenori on his project. But Hidenori, welcome, and floor is yours.
Thank you for the invitation. My name is Hidenori Arai. A little bit difficult to pronounce, but Hidenori or Hide or whatever, either is okay. I'm a geriatrician, the president of the National Center for Geriatrics and Gerontology, Japan. I'm a 2020 Catalyst Awardee funded by MMed, Japan Agency for Medical Research and Development. So the background is the number of people with dementia is estimated at 47 million in 2015 worldwide and expected to triple by 2050. Dementia and cognitive decline are key challenges for healthy longevity in all aging societies because dementia is one of the main causes of disability in older people. And it has a great impact on society with rising cost of health and social care services. Given the high drug development failure rate in Alzheimer's disease, especially for disease-modifying drugs, developing successful non-pharmacological strategy to prevent dementia is an urgent priority. So we planned this study. The name is JMINT. JMINT is a multimodal and multi-center intervention randomized controlled trial for older people with mild cognitive impairment. And we began recruiting the patient in 2019, just before the COVID pandemic. Recruitment was delayed due to the COVID pandemic, but in total, 531 patients were successfully recruited and assigned to the intervention and control groups. The intervention was also forced to be interrupted due to the state of emergency for COVID-19, but we have been able to introduce an online intervention and program because we need to ask the participant to get together in a room. So it's a kind of group exercise program. But the government did not allow us to do such group exercise inside because of the concern for infection spread. So we came up in a short period of time the Zoom-based online exercise program, and which was quite successful. Some participants could continue their exercise program during the state of emergency in Japan, which lasted almost 2 months. And in terms of the trial, this is almost 1.5-year intervention program or study, and the dropout rate is approximately 20% in spite of the pandemic and all the social restriction measures. In parallel, we are conducting a JMINT Prime study where 400 participants were randomized to control and intervention group. But in this JMINT Prime study, we are providing less intensive intervention programs, considering social implementation in the future. Originally, we got a 3-year budget from the government, or I should say MMed, but due to the COVID-19 pandemic, we had a 1-year extension. We are going to complete the study in November. So we have almost ready to analyze the data after November, although we need to do a lot of stuff like data cleaning and stuff and so forth. But I hope we can get the data early next year and maybe April, May, and going to publish the paper during 2023. The unique feature of JMINT is the involvement of a private company, Sompo Holding. Sompo Holding is an insurance company, and they're doing some care industry as well, and considering the future social implementation. In JMINT, we have collected blood samples, genome, and brain imaging data, in addition to neuropsychological and physical measures. And we are preparing to share the data with other similar studies worldwide after publishing the main paper. So we are collaborating with other researchers worldwide, which we call Worldwide Fingers, which is led by Professor Mia Kiefeld in Sweden. She is the founder of this kind of multimodal intervention study for preventing dementia. So we are very happy and very excited to share the data with other groups who are conducting similar multimodal intervention study. Thank you very much for your listening.
Well, thank you so much, Hidenori, for sharing this. And I hope you have lined up already. You took some notes and you do have questions to Hidenori, then this is the good time and space to ask them. Iliana, yes, go ahead.
So can you please elaborate a little bit about the multimodal intervention? What exactly are you doing? I mean, not
yes. The first one is exercise training. Exercise consists of, we ask the participant to get together once a week. The session consists of 90 minutes program, consisting of warm-up, aerobic dancing with others, resistance training, and group work. So that's the 90 minutes program for exercise. The second one is a nutritional intervention or counseling by a dietitian. Dietitian contact the participant every week and check their diet, healthy diet, for the prevention of dementia and frailty sarcopenia. The third one is cognitive training. We used Brain HQ, which was developed by American company, and they have some data to improve or maintain the cognitive function by Brain HQ. And we introduced the system, and that's the third one. And the fourth one is management of chronic diseases like diabetes, hypertension, and dyslipidemia. So those are the four interventions which was introduced in our study.
So no pharmacology, no drugs.
No pharmacology, no. Only pharmacological intervention for diabetes or hypertension. We allowed those drug treatment.
Thank you.
Yeah, that sounds really amazing. How it's like combining actually many things that could be also like cost effective, like getting together and having exercise together, or just like changing your diet instead of consuming super expensive drugs. That's I think, and it's also fun. I think when people are getting together, that sounds like, especially old people, I think they look to be social.
It was great fun to see the participant to improve their exercise capacity during their exercise session. So that was great fun for us as well, and very impressive.
Awesome. In the group, do you have some more nuggets to ask from Hidenori, Alex, for example, or?
Yeah, I have a question. I'm curious, what has been for you the most effective ways to measure the outcome for the patients or their experience?
Well, the outcome measure is a composite neuropsychological test, including MMSE and other neuropsychological tests. And we also measuring physical fitness, like muscle mass, grip strength, and also QOL, mood. We are measuring a lot of things. It takes about 1 hour to complete the study. So the participants are always exhausted after all the the test. But as I mentioned, we take the blood, some biomarkers, and also genome and MRI image before and after the intervention. So we have collected a lot of stuff. So we need many researchers to analyze the data, because otherwise without many researchers we cannot conduct the whole analysis. We have only small team, so we are lack of human resources to analyze a whole bunch of data, and we are using the Fitbit to analyze the daily activity of the participants. That's a huge amount of data, but we have no idea how to analyze the big data. So that's a huge challenge for us.
Well, maybe there is even in this group some people that maybe can come up and share some trick later with Hidenori, how to maybe help tracking that data. I think if
that'll be great.
That would be
actually. So I'm, as I said, I'm in a group, and I'm not the expert in artificial intelligence, but the group from Hong Kong and Professor Victor Lee will speak later. And you may want to get in touch with him. He's in Hong Kong, and he's an expert in analyzing big data. So perhaps that's an idea.
Thank you.
Awesome. Do any of you have more questions for Hidenori? I have actually one question. What would be maybe like in a perfect case scenario? I understand that you're also like looking into genome. Do you think that if your study is going well, and maybe we see the results in the springtime, maybe based on the markers you discover, do you think that you can already like predict in the future that the interventions could be like earlier? Because I understood that this group of people they're already elderly people, but I think sometimes the earlier you start with the intervention, maybe that could be the key here at one point as well, to kind of calculate what's the right amount.
Yes. That's what we exactly plan to do. We are trying to subgroup the participant based on their genomic data or serum biomarker or physical activity or so forth, and then see the effect of intervention. So we can I don't think all the participants are responsible to this multimodal intervention. Some people are very responsible while the others are not. So we need to come up with the next step to improve the cognitive function for the non-responders. So that's a very huge challenge for us as well. And also we have a genomic data. We are conducting whole genome sequence of almost 300 participants, and then we have discovered a Japanese specific gene for Alzheimer's disease. So it's a very interesting, to analyze whether we have those participants may have some Japanese specific dementia or Alzheimer's gene, and those genes might be protective or susceptible to multimodal intervention. So, but the sample size is not so huge, but we might have some hint.
Well,
can you share more about what is this gene? What's the name of the gene?
We have discovered one gene, sharping. The other still impressed, so I cannot disclose the name, but we have discovered, I think, at least two specific gene which are in Japanese. I'm not so sure those genes are applicable for other Asian ethnic group like Chinese or Taiwanese or others, but it's totally we could not detect those gene, the effect of those gene in Caucasian people. So that's a very specific gene. You can find the name of those gene by Shigemizu. I can put the name of first author in the chat, so you can search.
Okay, thank you. Very interesting.
And I see that there could be even potential for later follow-up studies that, you know, if you manage to
Yes.
kind of like do the great discovery in Japan, like here at our community, we have like having the brightest minds from Japan, from the US, from China, Singapore, Taiwan, Chile, and the EU, that maybe like a few years later we can, like, you know, try to customize that Japanese success, maybe with a little bit of twist for different, let's say, genotypes across the world as well. So that sounds very exciting. But thank you, Hidenori, for this. I think that was super exciting. And I'm now very happy to give the spotlight to Claude Goodman. He's from the US and sponsored by the US National Academy of Medicine. And he has been working on a project called CareBank, a peer care platform connecting elders for the pandemic and aftermath. So Claude, we are very excited to hear what's a CareBank and how you, especially I think now we are getting through the pandemic, but your project was also focusing on the aftermath. That tell us what's the aftermath and what we can look forward into.
Can everybody hear me?
Yep.
Thank you, Timo, for that introduction. Yes, I'm Claude Goodman. I'm the CareWheels founder, a biomedical engineer and germ technologist. I'm speaking to you today from Portland, Oregon, where it's early in the morning. So I will address your question as we go through the flow of my presentation. I have some slides today. To begin with, my expertise is in biomedical technology transfer, and my research interest is empowering people to amend the root causes of health inequity that undermine healthy longevity. These include the economic, environmental, and social disparities that adversely impact the social determinants of health. I'm a 2020 Catalyst Awardee, funded by the US National Academy of Medicine. Slide 1, please. Great. I see that it's up. All right, so my project, as Timo said, is called the CareBank. It's a peer care platform for connecting elders for the pandemic and aftermath by integrating AI, IoT, mobile, and Web3 technologies with behavioral economic principles to engage and reward elders for interdependent or peer-to-peer care services like mutual medication and safety monitoring, all from the comfort of home. Slide 2, please. That's not my slide 2.
That's
Sorry, hold on a second. Let me make sure we got the right deck up here. Oh, got it. I see what went wrong. Okay.
Thank you. Thank you, Catherine. So here you see the virtuous circle of peer care. We lost it again. There it is. Okay. Which I define as independence through interdependence. So the CareBank theory of change shows how inputs lead to impact by interconnecting people to promote a reciprocal care-sharing economy. We know that loneliness, medication non-adherence, and endemic inequities in our healthcare delivery systems preclude healthy longevity by disproportionately impacting the most vulnerable members of society, including elders and people of all ages living with disabilities. So what you see here is we start with our inputs, peers, elders as assets. The activities we engage them in are mutual medication and first response. The outputs are to reduce loneliness and incentivize self-care. And the outcomes are that peers help save lives and money. And our impact is to take this and scale it up to meet the growing needs of elders worldwide. So peer care technology connects people to promote a reciprocal care sharing economy. We began by building a smart home living laboratory for participatory design to explore how the Internet of Things could positively impact independence and quality of life with a team of pre-senescent people living independently with severe disabilities. They served as resilient proxies for frail elders because they have similar yet more stable cognitive, motor, and sensory disabilities. Yes. Slide 3, please. Thanks, Catherine. So here's the Care Bank solution, which is a combination of telecare plus a time bank. The CareWheels Living Laboratory demonstrated the value of engaging people directly to design IoT systems for their benefit. We learned which technologies worked well, and more meaningfully, we learned what helps people work well together. Technology enables the human interconnections that are the essence of peer care. The CareBank solution is a peer care network and the app that integrates telecare with a time bank. And here you see the app. Peers see themselves surrounded by their peers in their peer care network. The telecare component supports aging in place. It shows the status of the peers in the care wheel. The background color defines the current state of each peer in the circle based on a number of sensor inputs. And this provides peer care-based social connections and incentives for self-care, like self-medication management. The time bank component values peers as assets. It monetizes peer care services in time dollars, and it converts human capital into shared social capital. This automates the collection of accounting and sensor data for impact metrics. Next slide, please, Catherine. Okay. So what's unique about the Care Bank? Well, help comes when nothing happens, literally. The most common technology for elders who are aging in place at home, particularly those who are living alone, is what's called the Personal Emergency Response System, or PERS, help button. And you've probably seen these devices. The elder falls down, they push a button, and some anonymous person will then connect with them and try to manage their emergency, call emergency services, and so forth. These are sold on a fear-based approach, and they are, in my opinion, as an elder, infantilizing. And of course, if the elder doesn't push the button, help doesn't come. And there are many circumstances we've found in our formative research when elders will not push the button. And they range from being unconscious and incapacitated to feeling a stigma of having to wear a button and therefore leaving it in a drawer and not having it on their person when the emergency occurs. Compare that to the Care Bank, which is peer-based and incentivizing. Help comes, no button is needed because we sense everyday activity patterns and detect anomalies in those patterns before they become crises. So, let's see, this was slide 4. Next slide, please. So let me just say that since poor health is so costly, we have proposed a paradigm shift, which is to reward people for their healthy practices and outcomes by establishing collaborative care-sharing economies that pay people with community credits to take good care of themselves and each other. So this is how we do it. This is what I call the biotic ecosystem platform, And BIOTIC is an acronym for blockchain plus Internet of Things for interdependent care. Okay. So we are repurposing IoT and Web3 from surveillance capitalism and financial speculation to build proactive and predictive and ultimately preventive peer care networks that enhance our interconnections and empower our interdependence. CareWheels is developing the CareBank, a peer care platform that integrates smartphones with IoT sensors and social incentives to connect, detect, alert, and reward peers for their mutual support. The BIOTIC platform integrates sensor data with a novel proof of care algorithm to validate outcomes and reward peer care. And as you can see, we place these little sensors on a variety of artifacts in the elder's home, the pillbox, the refrigerator, for example. And these sensors report activity with an accelerometer, motion activity, through the app to the CareBank network in the cloud. We collect and process this data, and we inform members of the peer care circle when a person hasn't taken their medication on time, or when they aren't eating their meals. And the first person to respond by calling that peer who may be in trouble receives a reward in what's called time dollars, a reward for the time that they take to care for their peer. Our intention is to move from a conventional time bank to using a blockchain and the type of community credit and currency systems that are developing now, and to integrate the sensor data with a novel proof of care algorithm to validate outcomes and reward care. So CareWheels piloted the CareBank in the homes of elder participants aged 80 through 94, living in a naturally occurring retirement community here in Metro Portland, Oregon, during the COVID pandemic. Our pilot participants reported that the CareBank app is easy to use and provides and proved to be beneficial to help keep them connected safely at home while sheltering in place during the pandemic. Next slide, please. Thank you. So here are a couple of participant testimonials. The CareBank is proving to be beneficial to help our CareWheels group stay safely in contact as we shelter in place to protect from the coronavirus pandemic. I am thankful for participating in the CareBank program. Who knew how much we would need each other in this time of COVID? So the CareBank engages people in peer care for our mutual health and longevity, converting surplus human capital into shared social capital to rebuild healthy communities. It's designed to scale and serve 55 million low and moderate income American elders, whose numbers continue to grow today following the pandemic and current financial crisis. So we've used Catalyst Award funds to pilot the CareBank and develop our IoT sensor system, a low-cost, elder-ready system using Bluetooth 5 long-range sensors to provide reliable whole home telecare sensing of key activities of daily living, like medication and eating. This novel IoT sensor system furthers our mission to scale up the CareBank platform and propagate peer care. Slide 7, please. I looked at the global roadmap for healthy longevity. As President Victor Zhao wrote, the roadmap to foster healthy longevity includes strategies related to the social and behavioral enablers of health. The report's summary reiterates the necessity to increase human and social capital through productive engagement. The CareBank enables interdependent care by converting surplus human capital into shared social capital. From my U.S. American perspective, the great challenge to achieving these aspirational and equitable goals is the constraint on healthcare systems predicated on profits over people. Last slide, please. So, CareWheels Corporation seeks cross-sector partnerships to help develop open blockchain and IoT APIs that will connect a wide variety of healthcare providers and devices, including environmental and wearable sensors, diabetes and vital signs monitors, to serve diverse healthcare needs and drive technology adoption for healthy longevity. Thank you all for your attention, and thanks to NAM for this honor.
Well, thank you, Claude, for sharing this very exciting and very technological project with the potential to really like connect people. In the group, do you have some questions for Claude?
So I have a question.
Dinori.
Yes. So great system. I think it should be applicable in Japanese or other older people. So my question is that during the pandemic, older people lost the communication with other people, and they stayed at home. So their physical activity dramatically declined during the pandemic. And so they are getting frail and cognitively impaired during the pandemic because of the loss of communication with others. So my question is, can we use this care bank to improve social activity or social participation or other activity of older people?
That's exactly what the Care Bank is designed to do. I've worked with a group at Oregon Health Science University, the Alzheimer's research group here. And like your own research, it's clinically based, and the researchers have to do all the heavy lifting all of the time in order to engage the participants and to collect and analyze the data. So the whole idea of the Care Bank is to engage the participants themselves in this kind of mutual monitoring and reciprocal first response. What this does is it first addresses the issue of loneliness. I have peer care participants who've said, they were living alone, they were lonely, and once they had the Care Bank app, just looking at the app on their smartphone reminded them that they're not alone, that they're surrounded by a group of friends in their community who are looking out for them, and they're doing their part looking out for that person. So it's a real huge multiplier effect and an engager of people's participation to take better care of themselves by taking good care of each other. Good question. Thank you.
Thank you.
May I ask?
Yeah, Ilana, go ahead.
So from a practical point of view, I think this is great idea and great app. So how do you plan to kind of distribute it around the world?
Ilana, that's a great question. CareWheels is a nonprofit corporation. All of this research has been done with various types of foundation and grant funding, including the Catalyst Award. So it's very difficult, at least in the United States, to attract the kind of investments necessary to scale this technology up. My dream, my passion, is to share this with the world, and this is a fantastic forum to do that. So I'm putting it out to the world. I'm offering it to anybody who's interested. Please get in touch with me. I'm seeking collaborative partnerships because it's going to be a heavy lift to bring it out to different people, to tailor the app to be culturally responsive to different populations. And I'm looking for collaborators to help make this all happen. So thanks for your interest, Alana.
So will we have all the emails of everybody participating in this small group, in this round table, so that we can be in touch?
I'm not sure, Catherine maybe, or somebody like Lorenzo maybe can comment on that. Otherwise, what you can also do, if you want to share your contact details, you can put in the chat below.
Oh, okay.
So you can all write if you want to connect there. And then there is this 3 dots line where you can later click Save Chat, and the chat of this room will be saved in your laptop or the computer you're using. So you would get a copy of that. I think that would be maybe the easiest way.
I think that's a great idea. Also worth mentioning that we'll be posting, or we'll share the recording when it's available. We'll be sending you an email if you're interested in viewing it.
Cool. Yeah. And actually, maybe as a side note for Claude's idea, I have working in the startup world, I have seen like number of this kind of care startups popping up where there is usually like commercial background. The years I was living in Singapore, I remember there were like a few coming up that maybe even like your solution could be adding value to them, that if they want to kind of link across nations, or making it more affordable, because I think usually the commercial versions are based on the fact that you can hire people, or like, let's say the kids can hire caretakers for the parents, but this seems to be more effective and cheaper when elders help each other, and maybe, you know, they just need that infrastructure around the house, and that you know, getting acquainted with that app that exists.
That's a very important observation, Timo. Most of the commercial efforts, the products that have come to the market that use sensor technology to monitor elders in home are not sold to the elders, but rather to their adult children. And there are some inherent problems with this approach because it inverts the relationship between parent and child, and it infantilizes the parent. Many elders reject this approach. You know, today's elders, boomers, they grew up with 1984 and Big Brother, and are very sensitive to surveillance capitalism and its implications. We still believe in personal privacy, for what it's worth. And so the idea of peer care and using this technology to empower people is that the only people that the data is shared with are the participants in your own care circle. You own your data. You give permission to share that data. And frankly, as I have sought various types of investment, venture and angel funding, the first question they ask is, how do you monetize the data? And my answer is, it's none of your business. And their response to that is, goodbye. So, the problem that I have faced is trying to scale this technology up is to find appropriate sources of funding. And in the United States, if you can't tell a VC a 100x story about their return on investment, they're not really interested in funding you. And you know, some things work well that way, some types of innovations, but other innovations, particularly if you're trying to serve the underserved, if you're trying to create equity, this is just amplifying the disparity that we have between the very wealthy and everybody else. So the whole idea of rewarding people with a community credit, which, by the way, they can then exchange through the community care bank to purchase other services, like somebody to pick up prescriptions, maybe stock a person's refrigerator after they've been discharged from a hospital, walk their pets, do various house and yard work, intergenerational stuff. We're talking about creating a parallel economy within communities that uses a blockchain-based social currency in order to up-level everybody's quality of life and not be dependent upon the national fiat currencies and the national systems to help people. Because, the bottom line is when everything else falls apart, the only thing left is your community, the people you know, the people you care about and who care for you. That's the people we're trying to empower, and that's the majority of us.
Well, that's, I think, how our kind of race also kind of started, where I think we see like successful animals, they also like operating together. You can even look like the small ants, like, one ant alone, but, all together they can build, wow, big things.
Yeah,
In the meantime-
synergy trumps competition in the natural world.
Yeah, and especially I think small states, what they can accomplish while sticking together. Do we have more questions for Claude? Marcus, Alex, Camille, Lipping. Marcus, yeah.
Yes, thank you for the presentation, Claude. My question is related to how to explode this data. I understand the privacy subject is pretty relevant. I have it in my project too, which is related to telemedicine, and acquiring data is quite complex, and this is a great opportunity for learning from this data, even if it's in a close environment, to share this information to this group of selected people. It would be interesting if maybe you are doing it already, to apply artificial intelligence techniques to have a more elaborated feedback to the people. For example, if you are sensing the different situations and you have learned what that situation means, you can say more properly to this elderly care circle what is going on. So I don't know if you are working on that sense. I quite not understood maybe that you are already doing it, but that's the question.
Yes, so in terms of sharing the data for elaborated feedback, we train people to use the system by first self-monitoring so that they learn what the sensors are telling them about themselves. So they become familiar with what it means. And then we connect them into a circle of peers. And that way they're already intimately familiar with what the sensors, with interpreting what the sensors mean. And they can provide the kind of support to members of the peer group, if there is a problem, if a person hasn't taken their medication today, maybe they just forgot. What we find very interestingly is something that I call positive peer-to-peer pressure, that people don't like to have to disturb their buddies, to have to call them every time they forget their meds. So they become much more vigilant about taking their meds on their own when they know that their peers will have to respond if they don't. And there was actually a JAMA study a couple of years ago that looked at different interventions, paying people to take their meds and a variety of other things. The only intervention that was found to be effective was to have somebody who cares call and say, hey, you didn't take your meds. Okay? So that's on the level of the peers, how we elaborate the feedback. But also, we will be collecting, if this goes global, a lot of biomedical data. And we would like to be able to share that data. We would like to be able to participate with other researchers. So putting the data on a blockchain provides the ability to share the data from the micro level of peers to the group level of fellow researchers who want to be able to tap into subsets of that data in order to, let's say, validate a pharmacological intervention or something like that, and all the way up to the insurers who may be public or private, who want to look at the impact of this kind of a community-based technological peer care service on the quality of life and the reduction in the cost of healthcare services. In fact, what I would ultimately like to see would be for insurers to share some of the financial benefits of reduction in the cost of care with the care bank in order to help propagate and up-level it.
I think insurance are definitely important, and actually, I think Hidenori, you mentioned that you're also working together with Sompo insurance company, because I think health insurers and life insurers, what I have heard, but they are now also like getting more anxious as the healthcare cost is rising. I mean, the payouts often are rising, and as I have been talking also with the insurance companies, I understand that often the health product line is the loss-making one, and they have to compensate it from the profits from some of the other products. That definitely, I think this is like, you know, finding the right formula, how to kind of like, because I think insurance people, they're often more like financial. They kind of like look that the profits would be bigger than losses, but like translating that cooperation and prevention into something, I think if you manage to find a good formula how to sell them, maybe that's something. Or Hidenori, maybe you have a trick how like based on your experience, how maybe Claude could sell it to the American insurance companies based on your Japanese experience.
Yeah, we are collaborating with two insurance company. One is some holding, the other is another one. The other one's we have the other one. Both are interested in this kind of, you know, app development, and we are collaborating with those company to develop app. One is mainly checking the physical activity and frailty and so forth. And the other is for dementia prevention and like diet or exercise or something, you know. So I think many insurance company are interested in developing this kind of app. And the idea is to, you know, this is the, you know, the service for their customers. If they are other people or other, you know, people are for those insurance company get the, you know, company then can automatically get that kind of app to, you know, monitor their health and the future development of dementia or disability. So I think many people or many insurance company are very much interested in this kind of app. So yeah.
I think in the US there is maybe even like, it's a VC program, but I think United Healthcare, they are doing cooperation with Techstars that maybe they could be interested in what you are doing. That I don't know if it's the program still runs this year, but I think that's something that when I was scanning the network, I think that's one of the American insurance companies that might be interested in that as well.
Yes.
Yeah, but super exciting. And I think most exciting would be that maybe a few years down the line where we have those secret formulas how to kind of avoid dementia from Japan, and then, you know, implement it across borders into the US, how maybe also like the care bank could get people together to do those 90 minutes exercises that Hidenori was experimenting with Japanese elders, that it's maybe not just like when something goes wrong, but maybe also doing something together to avoid that something could even happen, that having those exercises together, or maybe also like, you know, I sometimes when I have been alone, you know, preparing a healthy meal alone, that's not fun. It's so much more fun when you have like friends around or your spouse, but like you know, doing those things together as well, especially those elders that have lost maybe some family members and have to do it alone. Adding those functions probably would help even further. Yeah. Does anybody still have, I think we are not kicked out of the room yet, so we probably could take a comment or questions. Yes, I think we have 5 more minutes. So if somebody would be still having a question to either Hidenori or Claude, or want to share some ideas that maybe could be useful for them to kind of scale up the operations, because being a catalyst was phase 1. I think there was also phase 2, and they want to maybe continue this journey. I think that would be currently great space to give feedback and share some maybe observations from your countries that could be maybe useful across borders.
I think eating is very important for older people, in addition to middle age or other generations. In Japan, we say solitary eating. Although they're living with their other family members, older people is forced to eat by themselves. In a different room with other family members. That's we call solitary eating. That is a very high risk for dementia and disability. So, this kind of family issue is very difficult to solve. And we in Japan, we have almost 6 million older people living alone.
Wow.
And some older people living alone are very active, but the others, socially inactive, and they are very high. They have high risk for disability or other risks. So that's a huge problem in Japan, maybe in other countries as well.
I'm wondering what's both of your take on robots, because we have seen that some companies, they have been also developing like
Yes.
robots and then
Yes.
probably using the AI and the technology. And as we are currently in the technology breakout room, what's your kind of like look into the vision that if you're missing those caretakers and people are living alone, and maybe sometimes they don't also maybe want to share that they are vulnerable, would be there market for this kind of robots maybe that would either help through the app or when something goes wrong, or even being the social robot. I think in Japan you have Pepper robots that
Yes,
have
Pepper,
kind of
yes.
social robot.
Right, but the price is still expensive, and we are developing. Some companies are developing communication robot for older people with dementia, but still, and they also introduce AI technology to communicate to facilitate the communication, but the quality is still not good. So it's still on the process of development. But the simple communication robot is already available, and almost 10,000 US, no. 1,000, couple of thousand US dollars something. Yeah, but it's not
That
so
sounds like a price of a latest iPhone as the phone prices are going up.
Yeah, Hiro, I completely agree with you. This is a cost and scaling issue. Most people are not going to be able to afford robots in at least the near-term, midterm future. In addition to that, I think it's a shame that we would replace human-to-human interaction, something that we've evolved over hundreds of thousands, if not millions of years, with AI and synthetic conversation. To me, that just seems absurd. I'm sorry, but when people are living and dying alone in their own homes because they don't have anybody to talk to. There was an article in the New York Times about lonely Japanese elders who were dying alone, and the only tool that they had to let anybody know that they were okay was opening and closing the blinds on their window to signal to a neighbor across the way that they were still alive. And that was the alternative to being discovered when the smell of death came under their door and a postman or somebody discovered it. Yeah, that to me is it's shameful. We have sensors. We have currently a $25 sensor, which we should get down to $5 or $10, that can at least give a signal like opening and closing a window blind to say, hey, I'm alive, I'm eating, I'm taking my medications. And this works 24/7. And if we connect this to a social care network, we don't need AI and synthetic conversations to connect people in meaningful ways, to improve their cognitive health, to improve their quality of life, and to give their lives meaning, to take care because they're taking better care of themselves because they know they're responsible for taking care of others. This is something that's so human and that many elders are no longer have an opportunity to do. Let's give people the tools to take better care of ourselves.
Yeah, and I think when people also have that, tools that they do themselves, they, I think, feel better, because I think there is this kind of mentality of being useful. And I think I have a feeling that I think one of the saddest thing is, like, when people get older, they don't want to feel useless. That, if they have that kind of like feeling that they are somehow still useful, that's like boosting up, then, just chilling there and waiting the sensor detect either you are dead or alive. Yeah.
I have a quick question. So on the topic of social isolation and dementia, my area of interest is hearing loss. And what we're learning, of course, is that hearing loss is a huge contributing factor to both. And I'm curious what your perspectives are around that condition.
Well, hearing loss is critical. Hearing loss and vision loss result in a person receiving much more sparse data than we're used to, and trying to understand the world with sparse data. And initially, the effect of that is to increase cognitive function, but at the cost of cognitive fatigue. So there's a very strong correlation between hearing loss and vision loss and concomitant cognitive decline. So it's very important to promote to promote good hearing. And now we have inexpensive technologies to do that in the United States. I believe the FDA just changed the rules about that these products can be commercial products and not only by prescription anymore. So we can help people to communicate better, and we can also preserve people's cognitive health by giving them more robust information with which to live their lives.
And maybe thank you, Claude, for this remark, and Hidenori, your take as well.